This is our presentation on fatigue, presented by Cece, Diana, Kyle, and Ariane. What is fatigue? Fatigue can be used to describe the difficulty or inability to initiate activity, reduced capacity to maintain activity, difficulty with concentration, memory, and emotional stability, or sleeplessness or an uncontrollable need to sleep. Here are some fatigue facts for you. 5 to 7% of people present to the primary care provider with a complaint of fatigue. Fatigue is defined as subacute when less than or equal to 3 months in duration. Only half of the people with tiredness or fatigue as a primary symptom will recover within a year. The average prevalence of chronic fatigue worldwide is 10%, and those with chronic fatigue syndrome are 1%. The diagnosis of fatigue. Pre-existing health issues, lack of fitness, distress, or stress may predispose people to be vulnerable to post-infectious fatigue. Patients described a cognitive, physical, and emotional impact from fatigue. Patients and practitioners agreed that the multifactorial nature of fatigue was an issue, and figuring out the cause in a timely manner was problematic, and that the symptoms could also not be resolved quickly. When physiological reasons were ruled out, practitioners shifted to psychological explanations. Patients also described the ongoing confusion regarding their causes. Practitioners assumed that when patients did not return, the issues had resolved. In fact, it was often due to how they thought the doctors wouldn't do or couldn't do anything to help them. Fatigue can be broken down into subacute and chronic fatigue. Subacute and chronic fatigue most likely are associated with underlying medical conditions, including chronic medical or psychological conditions, medication toxicity, or substance abuse. Two-thirds of chronic fatigue is identifiable, while the other third is classified as idiopathic chronic fatigue, or also known as chronic fatigue syndrome. And now for a case study. We have a 67-year-old female, and she comes into your office today with a chief complaint of fatigue. So we sit our patient down and get a good HPI. She reports experiencing increasing fatigue over the last 3 weeks and poor sleep quality. She reports her husband passed away last month from a heart attack and has a difficulty sleeping and frequently wakes up in the night. Every morning she feels fatigued and takes multiple naps a day. She states she tries drinking coffee throughout the day and she's been smoking to stay awake and active. So, our patient's past medical history. She has a history of hypertension. She says she takes lisinopril 10 milligrams PO daily. She also has a history of COPD. She takes 2 puffs inhaled of the tiotropium and she uses her albuterol 90 micrograms as needed. She has no allergies. Now we get to a little bit more of the social history of our patient. She says she drinks alcohol about 1 to 2 drinks per day. She's been an on and off smoker and reports half a pack a day for the past 10 years. On physical exam, our patient appears tired. She is dressed appropriately. She does have dark circles under her eyes and they appear bloodshot. She looks like she has been crying lately. Her posture is slightly slumped, but she answers all of your questions. Most of the time, they're with simple yes or no answers. She coughs a few times during the interview, but it's non productive. Her vital signs this visit: her blood pressure is 127/68, her O2 saturation is 95% on room air, she's 98% Fahrenheit, her heart rate is 65. Based on the history we have so far, can you think of your top 5 or 6 differentials you might have for our patient? These are the ones that we came up with: depression, anxiety, stress, the lack of restorative sleep due to sleep apnea, insomnia, or COPD, anemia, heart disease, and hypothyroidism. Now let's break down these differential diagnoses with pertinent positives and negatives. Her depression and anxiety. She recently lost her husband suddenly. You can add on to that stress. Not only did she lose her husband, but she might have picked up some additional household responsibilities and she may be the head of household now. And the lack of restorative sleep. She has a history of COPD. She reports not sleeping well. She reports waking up at night. She appears tired and she states that she's been napping a lot. The differential diagnoses continued. Heart disease. The patient has a history of hypertension, COPD, and smoking. She could have anemia. Many women have undiagnosed or undertreated anemia. She's also a smoker. She could have hypothyroidism. It can be an additive cause of depression and sleep disturbances. She's also 67, which puts her at a higher risk. For every patient that presents with a chief complaint of fatigue, there are a few of do not miss diagnoses. They include hypothyroidism, anemia, and diabetes. Additional points to remember: 75% of patients with fatigue have psychiatric symptoms. Anxiety and depression are the most common. 80% of patients with fatigue have a sleep disorder, especially obstructive sleep apnea and or insomnia. Since fatigue is so often associated with psychological issues, it's important to assess if the patient is a harm to themselves or others. Other safety concerns can include increased risk of falling, inability to care for themselves or others, and an increase in risky behavior, such as driving sleep deprived. A patient centered care approach to fatigue. It's important to use a holistic approach to manage fatigue. Since it is understood that not one thing is a sole contributor to fatigue, one must evaluate all of the possibilities and come up with the most effective interventions. Although physiological tests may have come up negative, it may be the psychological reactions to previous physiological events that may cause the fatigue. One must also consider many combination of factors when trying to decipher the real cause. Another possibility for treatment may be non pharmacological treatments, such as improving sleep hygiene, ambient music, or aromas during sleep. COPD and fatigue. COPD is a chronic disease that has many symptoms, including dyspnea, fatigue, sleep problems, anxiety, and depression. 98% of patients with COPD experience sleep issues, and fatigue is the most commonly reported symptom. In research done by Yilmaz and Kapuku, they found that progressive relaxation exercises decrease levels of fatigue in patients with COPD. 8 weeks of progressive relaxation exercises in patients with COPD showed to have an improvement in sleep quality. And based on this study, patients with COPD could benefit from home visit based pulmonary rehab programs and receive progressive relaxation exercises to decrease dyspnea, fatigue, and sleeplessness. Another research study we found dealt with aromatherapy and sleep quality. It was a randomized controlled experiment study with 59 people, and they were over the age of 65 in a nursing home. Prior to the study, all participants were given the Elderly Description Questionnaire, the Pittsburgh Sleep Quality Index, and the Fatigue Severity Scale. Members of the experimental group were provided lavender aromatherapy oil for 30 minutes before bedtime for 1 month. All participants were then asked to fill out the same questionnaires after 1 month. It was determined that the aromatherapy improved sleep quality and decreased fatigue severity. Aromatherapy may be an easy addition to sleep hygiene to promote better sleep and decrease fatigue. So, with all this information, this is our patient plan. We plan on doing some labs, a CBC, some chemistries, a thyroid stimulating hormone panel, and CK. We also want to refer her for a sleep study due to her COPD and reporting her poor sleep quality. She has not had one previously and does not use any nighttime CPAP. We want to give her some sleep hygiene education. From the research we found, there are some ways to help her sleep. We also want to give her a referral for support groups, for a counselor, and we want to check back with her. If she has no improvement within a month, we might start some medications, including an antidepressant. Thank you for watching our presentation on fatigue. I hope you learned something, and here are the references that we used.